Lawal is an erudite pharmacist. She's a fellow of the PSN. She has a FNA Farm, M Farm, DC Farm, and she's an MCPAN, that's a member of CPAN. She's the proprietor of Victory Drugs, which commenced since 1989. She's the founder Victory Vaccine Clinic, which is a standalone vaccine center. She's the vice chairman, Public Health Pharmacists Association of Nigeria. She's also an advisor to the ACPN Drug Information Center. She's into collaborative, she has done collaborative publications in international journals. She's a member of online health community groups like the Victory Diabetes groups, Victory Mothers groups, Victory Asthma Care Group. Okay, these are groups under her Victory Pharmacy. These are health community groups under her Victory Pharmacy. Then also, she's a member of several professional bodies like the Clinical Pharmacy Association of Nigeria. She's a member of West African Society for Parenteral and Enteral Nutrition. She's also a member of the African Society for Parenteral and Enteral Nutrition. She's a member African College of Clinical Pharmacy, which is not a small feat. She also has had some national awards like the annual Me and Baker Professional Service Award in Pharmacy, the 11th edition. She won that. She also won the Pfizer. She has also won the Pfizer Award of Excellence. She has also won the ACPN National Award of Outstanding Pharmacist. So she's somebody worth listening to. And anytime she speaks to us or speaks in any forum, there's always a lot to learn and a lot to take back home to help to improve our practice. So all that said, I would want to call on our speaker, pharmacist Mrs. Folashade Olufunke Lawal, to give her presentation. Ma, over to you.
Thank you. Good afternoon, distinguished colleagues, senior colleagues, my lecturers in house. I am delighted to share knowledge with us today. We will all be in it together. I know that patient safety and medication errors is dear to our hearts as pharmacists. And my aim today is that we go through together, learn together. It's a very big topic, very big. And no one person can do enough justice to it. So please journey with me as we go through patient safety and medication error. Briefly, this is my outline. I intend that we have a little poll. I'm not sure how that will play out. We'll look at my mission or our mission, patient safety, medication error, drivers of medication error, strategies to prevent or minimize errors, then take-home points and our references. This is the poll I have for us. It may not be easy to, I couldn't present it in a poll format, but these are the questions on my mind. In your practice, which type of medication error do you encounter most? Is it wrong dose? Is it wrong drug? Is it wrong patient? Is it omitted dose? Is it drug-drug interaction? Is it documentation error? And probably what you encounter most is not here, but I want us to just think through it. There's this quotation by James Reason, and it says that in healthcare, safety is not the absence of errors. It is the presence of systems that catch them. So we'll come across James Reason as we go along again, and this will make more meaning to us. So my mission this afternoon is briefly this, that as clinical pharmacists, we operate inside those systems that this man is talking about. We strengthen them, we challenge them, and sometimes we discover their weaknesses. Sorry, still saying this evening because my first presentation was meant to be in the evening and I forgot to change this, forgive me. So this afternoon, we will journey together through how medication errors occur, why they persist, and what we, as the drug information experts or drug custodians of drugs, can do to build safer, smarter, more resilient medication systems. I love case studies a lot because they drive home the point. And I want us to just look at this. This happened for real. And it happened to us. I mean, in my pharmacy. So Mr. Z filled a prescription for amitriptyline 50 milligrams for 1 month. After he left, the pharmacist realized that she had inadvertently dispensed haloperidol 10 milligrams instead of amitriptyline 25 milligrams. That meant that that patient would probably take 2 tablets of haloperidol 10 milligrams instead of 2 tablets of amitriptyline 25 milligrams. If this happened to you, how would you solve it? Just keep it, we'll come back to it. My question to us again today is this. When you hear patient safety, what comes to your mind? For me, what comes to my mind most is, what can we do to ensure patient safety? What can I do to prevent my patient from being unsafe? Now let's look at what WHO defines as patient safety. This is a framework of organized activities that creates cultures. When we are talking of cultures now, we mean shared beliefs of safety first. In your establishment or in my establishment, do we have a shared belief that safety is first? It creates processes. That's routine steps everyone should follow, or routine steps everyone follows. Everyone knows that when you are dispensing a medication, for example, the onus lies on us to explain to the patient verbally, no matter how busy, no matter how much in a hurry this patient is. It creates procedures, that's task-specific instructions. We have standard operating procedures so that all of us are doing the same thing. Behaviors, daily pharmacist duties, habitual patient counseling. It creates technologies. That's tools that make pharmacy safer. Thank God for technology. Technology has done a lot to improve practice. Then the environment, the physical pharmacy space. All of this in a healthcare that consistently and sustainably lowers risk, reduce the occurrence of avoidable harm, make error less likely, and reduce its impact if inadvertently it does occur. So we are looking at a comprehensive system now. What is medication error? I call this out from one of the online courses I'm doing, and it's based on US, basically. The Institute of Medicine says breakdown or failure at any point in the medication use process, from prescribing to use by the patient. Any breakdown or failure at any point in that circle is regarded as medication error. Then the National Coordinating Council for Medication Error and Prevention says that medication error is any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in control of healthcare professional, the patient, or the consumer. The American Hospital Association Institute for Safe Medical Practices, Health Research and Educational Trust says that medication safety is defined as freedom from accidental injury during the course of medication use. Activities to avoid, prevent, or correct adverse drug events which may result from the use of medication. So all these are definitions that are generally self-explanatory. Now let's look at what studies have shown us as far as medication errors are concerned. Of course, I can't have all studies here, just a few of them. One is that medication errors are the most frequent avoidable source of patient harm globally. And it says that at least 1 in 20 patients is affected by preventable medication-related harm globally. Prevalence of medication-related harm in low and medium income countries is almost double that of high income countries. And it's understandable. They have more of technology than we do. They use it more than we do. They have more enacted laws governing their practice than we do. So you can see that the system goes in a long way to influence things. The highest prevalence rates of preventable medication-related harm were in African, 9%, and Southeast Asian, 9% regions. I got this from a WHO document. It's in my reference. 1 in 4 preventable medication-related harm is severe or life-threatening. Now, this is another important point from studies. Patients managed in geriatric care have the highest prevalence of preventable medication-related harm globally, and I'm sure we can relate with this because they are usually the patients that have polypharmacy going on around them. They usually have so many conditions. There are many drugs. Their systems, their biological system is already wearing out. Their ability to manage drugs through kidney, liver is waning. They are the ones that can have this ACD score, high cholinergic burden, and all of that. So it's relatable. Now let's look at medication errors in terms of modern realities and safety principles. If we have a system that is complex, errors are inevitable because the more complex, the more likely that errors will occur. When we have environments with high workload, a lot of manual processes going on, fragmented information, then we are more likely to have errors than in systems that are not complex. Prevention depends on strong blame-free reporting cultures. And this is that are supported by digital reporting tools, automated alerts, structured root cause analysis. It's important that we have blame-free reporting cultures if we want to work against medication errors. Reason is this: the more people report errors, the more we all learn from the errors, and the more we are likely to reduce, minimize, or even eliminate those errors because we're all learning together. But if it's difficult for people to report errors or it's not blame-free, then many errors will get hidden and more of such errors will come up. Education remains foundational. That's clinical pharmacology, digital literacy, safe technology training. All of these significantly reduce preventable harm. The more we know about the medication, the more we are likely to reduce harm. Let me just give one very simple illustration here. One day, a patient called me on the phone. He was angry that he wanted a pack of diclofenac from the pharmacy, and they did not give him. So that was why he called me. Now, it was easy for me to handle that case because I knew the patient. I had saved his number, and I saved it. He didn't give me his name. So I saved his number based on the medications that he used. And he was on ACE inhibitor. He was on a diuretic. So I just told him, look, that drug would harm you. So. He was surprised to know that I knew so much about him. So because of the knowledge of pharmacology, it was easy to handle. Multidisciplinary teamwork is essential and is now strengthened by shared electronic records, the pharmacy, integrated clinical decision support systems. You'll agree with me that we are all trained to work together, to contribute a different quota to the patient. The physician's training is different from the pharmacist training, is different from the nurse's training, the lab scientists, and all of them, even though we have some common grounds. And when we all stay in our lanes and work together, then we are able to build a multidisciplinary team, and we are able to reduce or minimize errors. Now, why do medication errors occur? Manual prescribing, and this is a lot here in our own environment. Sometimes, in some groups, you will just see somebody is throwing one prescription and say, who can interpret this? And many times we are not even able to interpret. We don't know what the prescriber is writing. And sometimes it's so obvious that it's not clear. Sometimes it is misread, and those can lead to errors. Limited access to electronic health records. We need that. How many patients will store their information at our fingertips? We need electronic health records so that we have enough information about the patient that we can refer to, that will guide us. High patient volumes. I recall this happened when I was an intern. That was over 40 years ago. I got a prescription for diuretic thing. Sorry, I'm using daily for this patient. And I was wondering, the patient was still pregnant. Mudretic 250 milligrams. This we wrote Mudretic 250 milligrams. So I was wondering, how would 250 milligrams come to play? Total number of tablets was 55. And the usual dose is 1 tablet. So while thinking through, the patient was getting impatient. She was looking at me and I said, ma, this is like you would have to take this prescription back to your doctor. She was not happy with me. But I did a note for her to say I didn't get what the doctor wanted here. So she took the notes, went away for a few days. I even thought she probably got angry and had gone away finally, but she came back one of the days with a note from the prescriber, and he apologized. He was happy, he was grateful. He apologized profusely, said he was under a lot of pressure. I wanted to write methyl dopa 250 milligrams and wrote Mudretic. Then we have look-alike, sound-alike medicines. There are so many of them out there that can create problems. Under-reporting, like I said, due to fear of blame. Complex systems. The more complex the system, the more likely that errors will come in. Weak or no collaboration. Absence of qualified personnel. Well, we have a lot of that out there in many patent medicine stores, so many stores out there where drugs are freely available without qualified personnel to guide the use. Poor communication. This also happened to me when I was an intern. I dispensed clotrimazole vaginal tablets to a patient. And then the patient came back later to say that the problem was still on. Anyhow, after discussing with her, I found out that she swallowed the tablet instead of your 30 minutes. Those tablets were so big. I don't know how she did, but that was what she did. She said she didn't understand that I wanted her to insert it. Thank God that she was not harmed in the process. Sometimes it's organized drug storage. You just lump drugs anywhere. Or I also noticed that in some climes, yes, I discussed this some time ago outside the country when I was out, they had some medication errors that were results of arrangement of drugs alphabetically. So it was easy for somebody to pick propranolol instead of prednisolone, that kind of a thing. So sometimes that could also be an issue. Then environmental distractions. I'm sure there are more that you can add. But it's good that we start thinking of why they occur so that we can protect or prevent them from occurring. I got out these two quotations. One is that fatigue and interruptions are major contributors to medication errors. And you see a lot of that in our environment. You walk yourself out. Look alike, sound alike medicines continue to cause preventable harm. That's WHO 2023. I believe that these are already being worked on. But the fatigue is something that is not easy to work on now with all the Japa syndrome and 20 people's job becoming one person's job. So who contributes to medication error? Let's look at from the manufacturer. Sometimes we have poor labeling. And an example is methylprednisolone depot versus methylprednisolone IV injection. I saw this case. There was this patient that they administered methylprednisolone depot IV. And of course, because it had white crystals, it crystallized in the tank of the drip. You know, the drip usually has a small tank. So this little girl, I was just visiting that clinic and I saw what was happening. It was a little child, maybe a young adolescent, was now calling the attention of the nurses to it, and they were wondering what was happening. But because of the pharmacy in me, I intervened, I asked the caregiver to show me a pack of the drug. And I found out there was methylprednisolone depot that they used. In one small corner, it was written not for intravenous use, but it was not obvious. That should have been bold. Then similar packaging. This also, so many of the experiences that we share with us are experiences I've come across. I prefer to go with those experiences so that they are real. There was a time that we dispensed bromhexin syrup to a mother for a child who had asthma and they needed to use bromhexin syrup. And she came back to complain that when she gave the child the syrup, the child was reluctant to drink, complained that the taste was not the usual taste. Long story short, she found out that the package, the cat on the bottle was written, I was saying, because that error came from the manufacturer. Confusing dates, 30925. Which one is the day? Which one is the year? It becomes a problem. Manufacturing error, we know we have had that in Nigeria a few times in the past, where the ethylene glycol was used instead of propylene glycol, and the sad outcome of children dying. Then substandard or counterfeit products, we have a lot of that. So those are manufacturer errors. Let's look at prescriber errors. We've talked about illegible handwriting, and it's a problem. Right, wrong doses or wrong drug selection. For example, sustained release versus standard formulation, when the prescriber just leaves it open and it's the person dispensing that will now decide if it's sustained release, or there's even an error while prescribing it. The prescriber means standard formulation or prescribes sustained release. There can be errors there. Wrong diagnosis. For example, there was this patient that we saw some years ago. His asthma was no longer responding to the preventer inhaler he had used for 10 years. He had gone everywhere. They had given all sorts of, including aminophylline. He was just still having the wheezing. I'm sure we know that not all wheezing is asthma. Well, for that day, I was tricked because I thought that he had asthma because he had been on preventer inhaler. So we started looking for who could handle him. We referred him to a pulmonologist, and long story short, he came back with the verdict that he never had asthma. What he had was left ventricular hypertrophy. So he had been on the wrong management for 10 years. Sometimes there's incomplete patient assessment. The prescriber has not completely assessed the patient before prescribing. And when that happens, you may have the wrong drug because the wrong diagnosis might be made. Failure to also consider renal stroke hepatic impairment. For example, extended release amoxicillin clavulate in renal impairments with creatinine clearance less than 30 should be reduced. And if the prescriber does not consider that, that can be a problem. Lack of access to electronic decision support is also a problem. Then misconception. I put that in. I didn't say it anywhere. I put that in based on practice. I recall sometime that I got a prescription for a particular antibiotics in a rather high dose. And then I had to refer to the prescriber who said, look, from the experience, there are many fake drugs. So when they write the correct dose, it doesn't achieve it. They need to use a higher dose. And I had to correct that misconception that not all the drugs out there are fake. So what if the patient now buys, and then how do you evaluate it? How do you quantify how much of so the best thing is, let's go for what we know works and write the prescription appropriately. Wrong route of administration, like we identified earlier, incorrect duration of drug use can also lead to errors. Prescribing wrongly for a given individual, for example, error in identity, failure to consider pre-existing disease, failure to consider concurrent therapy. All of those can result in errors, medication errors, because we might be prescribing the wrong medication. Prescribing with inadequate or incorrect instructions. That's also a big contributor to error. Now let's look at it. Which is better? Is it to write 150 as 150 micrograms of clonidine versus 0.15 milligram? Hello? Am I being heard?
Yeah.
Okay. So which is better for us? 150 micrograms of clonidine versus 0.15 milligrams. Clonidine comes in 100 micrograms or 150 micrograms. Then we have the into 0.25 milligram versus 50 microgram. 0.1 milligram atropine versus 1.0. That 1.0 milligram can easily be read as 10 milligrams. So these are sources of error. This just says 0.5 milligram, and there's no zero before the point. So we can be read as 5 milligram. Then us now, dispensers, pharmacists, pharmacy technicians. Selection errors due to look-alike, sound-alike medicines can also be a problem for us. Selection error due to distractions, or if we arrange our medications wrong, incorrectly or anyhow. What we have tried to do that worked for us in my own pharmacy is in our prescription, because we have a prescription area separate from over-the-counter, completely separate. So we have tried to arrange drugs in their pharmacological activities. And then under every pharmacological group, we now try to arrange drugs alphabetically. That's for us has worked to minimize errors. Sometimes there's a wrong diagnosis, especially for some of us that
Okay, hello.
we are diagnosing conditions that we probably should not diagnose at all. So sometimes we make errors there, or we are handling the wrong patient. I recall many years ago, a patient came in, and a lady, she brought in a lab report, and the lab report showed positive malaria test. So the pharmacist dispensed malaria medicines for an adult because on the lab report was written adult. But by the time the lady was buying more drugs, she went to the over-the-counter to get syrups for the child. That was when we found out that there was an error on the lab report. It was for a child. So from then, we included that in our processes that we must still ask a lot of questions, get more information, not just assume that what we are reading is correct. So sometimes you're handling the wrong patient. The mix-up of medications, where ear drops is given instead of eye drops, that can also be a big deal, especially for drugs like chlorphenicol. The eye drops and the ear drops, there's a lot of difference in their composition per drop. So if you used ear for eye, you could get that eye into trouble. Poor labeling. Yeah, this is another interesting one. The patient called to say they gave her a drug somewhere, and they asked her to take 5 ml slowly. Now, how was she going to administer 5 ml slowly to the child? Is it that she will be dropping it drop by drop or what? So we asked her to bring it, and we found out that what the person wrote was 5 ml 8 hourly. The 8 hourly now joined together 8 and hourly and look like slowly. Inadequate verification steps, for example, guessing the prescriber's legible handwriting instead of confirming can also introduce errors from the dispenser. Manual dispensing without barcode checks, because barcode checks are specific to the product and they will betray if the product is real or not. Let's look at nurses and caregivers. Sometimes wrong time administration of drug. I've seen that happen in a number of cases where because of handing over, and then the nurse just discovers, oh, I've not given this drug at so time when I should. Or sometimes they're overwhelmed. They have a lot of work. There's probably one nurse or just 2 nurses to a whole ward, and they are going from bed to bed to administer medication. By the time they get to probably the middle or last patient, the time had already gone, especially when there are many of them to be administered drugs to. Then sometimes we have missed doses, wrong patient due to poor identification. I recall a patient told me I experienced, a child was on admission in one hospital, the child was ill, and then the day for discharge, she was waiting for the discharge procedures when a nurse just came in and wanted to set up a drip for that child, metronidazole drip. So she was wondering what was the matter. The child had been discharged, was there, and he said our senior nurse asked her to come and set up the drip. Long story short, it was that the nurse said, go to room B, and she went to room D. So documentation gaps can also occur. Wrong devices, for example, 5 ml syringe being used for insulin that is in IU, and somebody was trying to convert IU to ml. Communication gaps. This also happens in some facilities where you have many physicians managing the patient. The physician comes, writes something, and then another physician comes to probably overrule that, but didn't cancel the former one. And then you will hear things like they didn't cancel, so everything just has to go. And then misinterpretation of prescriptions too can occur. So let's look at the patient factor. One is
ọmọ náà
known.
rẹ̀ mọ́ ọwọ́ wọn lè yí náà nà. Oh. Okay. Yeah.
Can I go on?
Last man standing. Is the shop? It's off there.
Pharmacist Abbas, you are disturbing us. Can you mute Pharmacist Abbas?
Non-adherence, and this may be due to innocence. I recall one day one patient came and was like, Mr. Lawal, will I die? I said, what happened? He went to the hospital and he was given ciprofloxacin tablets along with paracetamol and some other tablets. So the paracetamol was labeled 2 or 3 times. Ciprofloxacin was 1, 2 times, but the ciprofloxacin was big like paracetamol, and inadvertently swallowed 2. He had taken 2 that night, 2 in the morning, before he realized that it was ciprofloxacin he was taking instead of paracetamol. So sometimes those errors occur from the patient. Sometimes they misunderstand instructions. I recall a patient that got, is it azithromycin? Yeah, powder. And didn't allow it to be mixed. Decided to go and mix it by herself. And then she now poured the powder, the spoon inside, she filled it with powder and poured it in the cup for mixing, added water to it to give the child, because she didn't read through it. The cup was meant to measure water, pour into the bottle and mix the syrup, then get out 5 ml. But rather than do that, she poured powder 5 ml to fill the 5 ml spoon, poured it into the mixing cup and added water to fill it up. How that child would take it was not a problem. Then sometimes also misconception. In these days of alofantrin, we had this case where, alofantrin then was a lipid motivated drug, kind of, because it got absorbed in presence of fatty meals. And the absorption was erratic, sometimes as much as 6 times what it should be. So the instruction then was to take it 30 minutes before meal and avoid fatty meals while on it. But this elderly man bought alofantrin. The pharmacist told him, because he did say that the pharmacist told him that he should take it 30 minutes before meals. And the pharmacist wrote it on him. But when he got home, he decided that pharmacist was too young to understand that people don't take medicine before food, and that should be after food. So he started a bowl of eba with egusi soup and all the palm oil inside. And as soon as he was done, he swallowed alofantrin, and then he came down with terrible arrhythmias. He ended up in the hospital. And then, self-medication is very common in Nigeria, unfortunately, because there are many outlets through which they get even prescription drugs. So they self-medicate, they do things, and the more that is done, the more the chances of errors occurring. Use of herbal products without disclosure too is another source of medication error. Sometimes the herbal products they're using might interfere with the prescribed medication, and the prescriber would not know because there was no disclosure. Memory impairment. I had this case many years ago. This elderly woman, she inadvertently took doxazocin instead of diclofenac because she had memory impairment. She was already into dementia. It was just starting, and she thought she was taking diclofenac, but she actually used doxazocin, and she didn't have any indication whatsoever for doxazocin. We had to manage that case along with the doctor, the GP, and we were asked to keep her monitor. Interestingly, she had never been hypertensive, but her blood pressure at the end of the day, she was so why I did that to do, but that was all out. Access to prescription medications. Many pockets, healthcare is more find patients seeing the and so they have different Sorry, I got thrown out. Permit me to continue where I stopped. Can you see my slide?
Yes, it's back now, ma.
Okay, thank you. So, yeah, prescription, non-medical access to prescription medications. I think I've talked about that. Doctor shopping, so many problems there because you see one patient seeing different doctors. I recall a patient sometime that was, yeah, a doctor placed her on, I think, lisinopril and indapamide. And then she was given that brand. She saw another person who also gave her another brand of lisinopril and indapamide, another brand. And she was using everything because she thought she was to use everything. So at the end of the day, she said she was having some feelings in her head that was like some sort of neuropathy. So she went to another GP and they placed her on carbamazepine. And everything just started escalating. At the end of the day, she thought it was a spiritual problem. And she went from place to place until one day somebody brought her to us. And we looked at all the drugs and we suspected that she probably had some form of electrolyte imbalance. And we sent a sample for serum electrolytes and they were deranged. So we referred her, we called in a physician, and we withdrew the indapamide, the different indapamide she was using, and later she got out of it. So sometimes those things introduce error. Then poor health literacy is also a common problem with patients. Like I said, these are, there are so many, so you may add to the list. Probably we'll have time to discuss and then you can let me know the ones I have left out. Now this speaks to classification of errors. And there are different categories. There are some circumstances, that category A, this is circumstances or events that have the capacity to cause error. Category B, error occurred, but the error did not reach the patient. Let me give an example of that. Many years ago, in the early years of my practice too, I dispensed a skin ointment because both of them were small. They had the same name, except that one was for the eye and the other for the skin. if I could recall, I think it was Theracotrin. I dispensed the skin for the eye, and the patient had gone before I realized it. Unfortunately, I didn't have the patient's details. So the only thing I could do at that time was just pray. And I prayed, I said, God, please help me. I don't know how you will do it, but just help me, because I wouldn't want this man to put the ointment in his eyes. Interestingly, the man came back about some days later to say he couldn't find the ointment anymore. So he could not even use it, he misplaced it. I said, God, thank you. So I told him that there was even an error, and we corrected it. So there was an error, but it did not reach the patient. An error occurred that reached the patient, but okay, maybe this one is, I think, more like it. The error occurred. The patient handled it, but it did not, no, it's still category B, that's my example is saying. Category C is different. The error occurred, reached the patient, but did not cause patient harm. I think I gave an example of that some time ago. That patient that swallowed suppository instead of inserting, the patient did not come to any harm. An error occurred that reached the patient and required monitoring to confirm that it resulted in no harm to the patient and or required intervention to preclude harm. That's category D. Then when we have category E, error occurred that may have contributed to or resulted in temporary harm to the patient and required intervention. That also happens a number of times. Category F, the error occurred that may have contributed to or resulted in temporary harm to the patient and required initial or prolonged hospitalization. Sometimes patients end up in hospital because of some errors that have occurred. Error occurred that may have contributed to or resulted in permanent patient harm. Those ones too happen. I can't readily think of any now. Error occurred that required intervention necessary to sustain life. Then the category I, error occurred that may have contributed to or resulted in the patient's death. I think there was one case some time ago. I will look at that case later on that I heard of, where a big error occurred like that because the patient was on some medications that were interacting with some others, and the kidney got affected. And at the end of the day, that patient did not make it. Now let's look at this picture. Can you see this man wanting to climb the bridge? I don't know how he wants to do it. And then it says, hi, I'm that bridge you said you'd cross when you come to it. This is not the kind of bridge you want to cross when you come to it. You must have given a thought before. And I'm using this to illustrate errors, medication errors. We cannot wait until medication error occurs before we start thinking what to do. The best thing for us to do is to preempt that these errors can occur, predict, and then guide against the errors occurring. That's the best solution. So how can medication errors be prevented? Well, back to our psychologist James Reason, and he says that two major considerations is either we're looking at person of human approach or the system approach. Well, as a psychologist, and from the research he did, he found out that person or human approach is not the best way, because human beings, to err is human. Human beings being who they are, they will likely commit error at some point. So the best thing is, let's look at the system approach and focus on internal safeguards. What are those things we can put in place as in our facilities, in our workplaces, to prevent errors or to minimize them? Or if the errors will occur at all, let them not be errors that can be fatal. And that brought about this Swiss cheese model of error causation. I came across it in one of the modules that I am looking at. So this shows levels at which intervention can occur to prevent error. And it says that if these levels have issues in them, let's say, for example, now, we have a patient, see a doctor, and the doctor probably didn't get enough information from the patient to make the prescription and prescribe something that is wrong. By the time the patient gets to the pharmacist is in a position to interact with the patient and spot if there are issues. If the pharmacist failed there, there are already 2 levels of failure now. They are aligning and gives out the drug to the patient, or passes the prescription to the next level, and that person too did not spot any error there, gives the drug to the patient, then there's a high likelihood that patient's safety will be compromised. I don't know if you are getting my point. So it's a system that helps us to look at different channels at which we can block errors. By the time the prescription gets to us, it's important that we look at that prescription properly. If there are errors there, we should be able to spot them and get them corrected. But if we don't play our roles when the prescriptions get to us, and then we hand over to the next level, probably the person dispensing, and that person too does not pick the error, then there's a high chance that the error gets to the patient. Sometimes it is that the patient does not even read, and there's a problem. So this takes me to the 3 pillars of safety. One has to do with systems and technology, people and training, teamwork and communication. This slide speaks to strategies to prevent or minimize medication errors. Number 1, we need to strengthen systems before error occurs. As simple as arrangement of drugs is, that is one way to minimize error occurring. When we have look-alike, sound-alike drugs, we should know how to separate them. For example, many companies, because they have their patterns of doing things, they want to maintain their colors. They use the same colors for the same strength of drugs. You might have 5 milligrams, 10 milligrams coming in the same color. And if one is not careful, it's easy to pick 10 milligrams as 5 milligrams and dispense to the patient. And if the patient is not okay. So when we have cases like that, it would be nice to separate them as much as possible so that we are not mistakenly picking one for the other. Then let's implement standardized protocols, checklists, standard operating procedures. So every process, every stage in the pharmacy, in the dispensing, every stage that the drug passes through, somebody somewhere is checking. And that will help us to pick errors. For example, let's consider expiry. At the time the drug is being supplied, expiry dates must be checked. At the time the drug is being issued out, whoever is receiving should check the expiry dates. We should also have people check expiry dates on the shelf. We should have also a culture of, before dispensing, check the expiry dates. I just use the expiry dates as an example because that may be easier for us to relate with. So that's the process, and those are protocols that we need to ensure. Use electronic prescribing to eliminate handwriting errors. Very, very important. Unfortunately, we are still far from that as a nation. Then adopt barcode medication administration for verification. Ensure organized drug storage with clear labeling and LASA separation. I mentioned that when I was talking about protocols and procedures. There's a direct code that says safety is improved when systems are designed to prevent, detect, and mitigate errors. Safety, yeah, I think I've said that. Let's talk about reducing human factor risk. Manage workload and reduce fatigue through staffing optimization. Sometimes we overwork our staff. Sometimes we even overwork ourselves, and the burnout, the fatigue, more often than not, contribute to errors. So it's important that we don't do that. We need to minimize distractions in dispensing and administration areas. So if we are positioning a screen to educate the patient, we should position it properly. Phone calls are also some other forms of distractions in dispensing and administration areas that might lead to errors. Somebody is constantly on the phone and also attending to the patient, handling prescription, doing everything at the same time. Encourage double checks for high-risk medications in particular, like insulin, anticoagulants, opioids, double checks. Especially if you are into compounding, you need double checks. Provide continuous training in clinical pharmacology and digital tools. It's also important that we produce improve communication and documentation. We should ensure, we've talked a lot about electronic tools. They are there for those of us that want to use them. They might be expensive, but they save us a lot of costs if we are barcoding our products and we select them with the barcode. We should ensure complete and legible documentation. This is also very important when we are documenting. It's important that we do it thoroughly. That prevents or minimizes error because the next person coming is able to look at it. I recall a case I heard of some time ago. I think the original container was for digoxin, and then somebody, the digoxin had been exhausted, a bottle, then somebody put some other products in it, maybe furosemide or whatever, and didn't tear off the digoxin label that was on it, but just wrote furosemide in one corner. And that was an issue. The person dispensing thought it was digoxin. So there were lots of issues there. That's because the documentation was not properly done. It's also important that we promote multidisciplinary teamwork and shared decision-making, very important, because there's no one person there's no one healthcare professional that can take the place of all the other professionals. And it's important that we stay in our lanes so that we are making the right diagnosis. When those who are trained to make the diagnosis, come up with the right diagnosis and issue prescription. The prescription goes to the pharmacist, who is also trained to ensure that there's a rational, the prescription is rational. It's the right drug for the right patient looks at all the rights that must be looked at. And if there is anything wrong, should be able to communicate with the prescriber. Those are areas we need to look at. Sometimes when you notice errors, sometimes the prescriber may not be receptive to sharing knowledge with you or discussing it. I remember many years ago, yes, those years of combination of mefloquine with sulfadoxypyrimethamine, yes, and also alofantrin. So there was this patient that brought a prescription for alofantrin. And while I was still studying it, all I saw was just alofantrin actually. The patient read through me. I was like, do you have any concerns? I said I wanted to know what was happening. And then the patient said that the child had symptoms suspected to be malaria. Then it was not very common practice to test before treat. And the prescriber prescribed sulfadoxypyrimethamine with mefloquine combination. So that had been used a few days before. But rather than the child get better, the child became very active, was jumping up, and they went back to the prescriber, who now prescribed alofantrin. Now, if we had dispensed alofantrin shortly after mefloquine, we would have done a lot of harm to that child because of the effects, QT prolongation, and all of that. So it is, and mefloquine stays for long in the system. So it's advised that we must allow at least 3 weeks after mefloquine before we administer any drug like alofantrin. Unfortunately, getting to the prescriber was not easy. What we had to do was to refer them to another physician, preferred, I think a pediatrician, and all they did was, okay, they now re-evaluated the child and placed on diazepam, and everything resolved. So multidisciplinary teamwork is key to preventing or minimizing errors. We should encourage open, blame-free reporting of near misses. Very important. That's where we all learn. Because like I said earlier, to where is human? We are humans. There are some errors that may not be pardonable, where processes are deliberately breached. There's a process on ground. I recall a situation where somebody was advertently given the wrong drug just because the person administering it did not follow the protocol. So in that case, there had to be disciplinary measure when everything came to the open. Let's leverage technology, AI-driven clinical decision support for interactions, dose checks, allergies. These are important. And when we're checking for interactions, it's important that sometimes we may need to check more than one literature. Telepharmacy for remote verification and counseling. Automated dispensing cabinets to reduce selection errors. Digital image capture for verification and audit trails. These are just all what we can do with technology. Now let's look at our Nigeria-specific enhancements. We need to reduce reliance on handwritten prescriptions. I've said that a number of times. We need to improve access to renal stroke hepatic function tests when the patients bring prescriptions to us. And we don't even know who this patient is because we are not working together as a team. All we have seen is the prescription. We don't know if the patient has renal compromise or hepatic compromise. Then there's a problem there. So for drugs that depend a lot on the renal function, hepatic function, and are affected by them, we have to be more alert. We have to probe. We need to find out more about such patients. Then there's a need to strengthen NAFDAC class alerts, look-alike, sound-alike alerts, and counterfeit detection. I think that there should be more done in ensuring that look-alike products have distinguishing physical factors that can distinguish them so that the errors are minimized, especially for those that are very sensitive issues. Then we should expand telepharmacy in rural and peri-urban areas. Those areas, there's so many things not working because of the paucity of healthcare professionals, and there's higher risk of medication errors. So we need to expand telepharmacies for qualified professionals to reach them. We need to promote digital literacy among pharmacists and technicians. This is an example of a look-alike product. One is lignocaine hydrochloride, and the other one is sodium chloride. They are completely different. So we should identify them, we should separate. Then we might also decide to use Tallman lettering. That's the conspicuous, the distinguishing letters are written in bold capital letters. Then we might apply color-coded labels or shelf markers. It's also important, like we have said severally, to implement barcode scanning. That helps to identify the drug better. Therefore, high-risk medications, digital image capture. It's important that we avoid ambiguous or incomplete verbal orders. Sometimes we tell our patients what to do and leave it at that. It's good that we get feedback from them. It's good that we are sure that they understand what we are saying and we should stay right. Sometimes for us in community pharmacy, it's not the end user that we are relating with, and can also be a challenge. It can promote medication errors, because by the time this person goes home to relate the message, there can be a problem there. So when we have that, we need to pay more attention. We need to do some writing. Thank God now that we can use our phones to call, to talk with the person, to explain, to get feedback, especially with artemether lumefantrine dosages. We had so many issues those days. People would just not understand it and they would use it wrongly. Thank God that it has a wide therapeutic range. And that is what must have saved many people. I had a case of a patient who called to say that she took 3 tablets at once instead of 1 of the by-6. So, and then some of them, they just don't relate with this first dose, then 8 hours later, and all those things. Use structured communication tools. Ensure all instructions are clear, complete, no ambiguity whatsoever. Very important. Document changes immediately in electronic or paper records. If there are changes, it's important. For example, your patient has been doing well on a particular medication and is changed, or the status of the patient changes. Probably the patient will had normal renal function, but along the line, the renal function has been altered, has reduced, or is compromised. Then it's important that we document the change. We should encourage multidisciplinary clarification without fear of blame. I recall the patient many years ago. He came in with a prescription. He had been on drugs for hypertension, diabetes, and he was on the high dose metformin and some other drugs. So that usually he would come in, fill his prescription, then come into the care room where he was, would take his vitals, talk with him, go over his medications. So he came in with the medications he had bought, and he came in with the medications he had bought and his prescription. He handed over the prescription to me, and I was talking to him for me to file. Now, I noticed that the prescription was different from the drugs he bought, because usually I was keeping records. So I had to ask him, sir, this is not what is on. He said I should not mind the doctor, that he was doing well on his former drugs. And now the doctor changed it to something that He didn't like at all. So what happened was that he had a prescription that covered about a month. He had only filled a week of it. In between were some tests done. So the doctor asked him to come back. When he went for the test, he now had stage 3 renal failure. And the doctor had to change his prescription. So he collected the new prescription. He held on to the old. He had a copy of the old. He held on to it. He bought a few of the drugs on the new prescription, tried it out, and didn't like the effects. He said they made him probably not sleep well. I can't remember his complaint now. So he decided on his own that doctor was on his own. And he decided to be filling the old one, which was still valid by the date. So I had to call the prescriber to get all the information because I didn't have his case now. I didn't know he had stage 3. It was when I called the prescriber to say, look, we have a problem here. Your patient says he was doing better on his former drugs and you've changed them. Then the doctor explained to me why he had to change them. And then we were now able to do a compromise, do another change, and everything was resolved. Use telepharmacy for remote verification when needed. Save those rights in preventing errors through clear documentation. Modern safety guidelines emphasize precision, clarity, avoidance of dangerous abbreviations. For example, DC, to mean discontinue, can mean something else as well. So we should avoid these abbreviations as much as possible. Somebody wrote HCl and it was read as KCl. That's a big problem. DPT versus small DPT. So SC versus SL, IU versus IV. There's so many of them. I had this prescription too. The doctor wrote TCA. Though that one was just a drama because the patient was looking for a drug called TCA. Meanwhile, what the doctor meant was to come again by so date. So those abbreviations can be an issue. Imagine there are 40, with the 40 close to the L, and then the 40 away. And then because the 40 was close to the L, it was read as in there are 140 milligram. I also had of a case, though that was not an abbreviation problem, where the patient gave the patient gave a diuretic instead of prednisolone. And the prednisolone dose was like 8 tablets. So he gave 8 tablets of the diuretic, which affected the patient badly. Dosage label concerns 100 milligram per kg 6 hourly versus 100 milligram per kg per day, divided 4 equal doses given every 6 hours. I'm sure we can see the difference. When you read 100 milligram per kg 6 hourly, sometimes it can be very confusing. You're not sure, is it that we should give 100 milligram per kg every 6 hours, or is it 100 milligram per kg in the day that you want to divide into 6 hours, 6 hourly dosing? But the second one is quite clear. It says 100 milligram per kg per day, divided in 4 equal doses given every 6 hours. So good practice ensures that units are properly used, grams versus grain. It ensures prescription instructions are clear and well written. For example, for a good prescription, we should have drug name, dosage strength, the number, the frequency of administration, the route of administration. Then we should be fashionably conservative. So it's important that you know your patient's conditions. And that's a challenge for us in community practice. Because many times we always see the prescription. So we need to do more collaboration to be able to break that barrier. We should pay attention to past history of hypersensitivity. Very important. A patient has reacted to a particular drug, for example, sulfonamide reaction. Interestingly, sulfonamide reaction can go into some other dimensions. My own daughter had sulfonamide reaction, and we usually would avoid sulfonamides. But there was a time she had some GIT problems in the US, and then she was placed on omeprazole. And she reacted, the typical sulfonamide reaction to omeprazole. That was when I went in and found out that omeprazole has a metabolite that has a sulfonamide. So they had to stop at that first dose. They could not continue it. Take notes of patient's occupation. Prescribe a drug which is familiar to you. The importance of patient's occupation is sometimes it might affect adherence. It might also, maybe the patient is exposed to some substances that might be counterproductive to the patient. Prescribing a generic drug, know the company in terms of bioavailabilities so that you are not using substandard products. Avoid overprescribing and overstocking. Avoid polypharmacy. Spend time to educate patients, talk with them so that you can understand where they are coming from. And this takes a lot from us in community practice. I don't know how we will solve this, because sometimes you find yourself spending almost 1 hour on just one patient, especially when you do medication use review. They bring different kinds of, you see different drugs, including agbo. That's what I do. Sometimes I tell them, when you are coming, come with the agbo as well, because those ones are silently doing something. I may not be able to know what it is, but at least I know that there's something else, and then we can counsel appropriately. Some medicine started should be completed. Some medicines taken for long should not be stopped abruptly. It's important that some medicines taken for a long time, we should know that they may lead to abuse or dependence. And then regular show and tell. That show and tell is like medication use review. Ask them to bring, they collect drugs from different areas. We've had cases where patients talks about putting prednisolone in water and soaking their feet in it. So this is show and tell. Then let's go back to our case study. So Mr. Z filled the prescription for amitriptyline 50 milligrams for 1 month at the community pharmacy. After he left, the pharmacist realized she had inadvertently dispensed haloperidol 10 milligrams instead of amitriptyline 25 milligrams. How would she solve it? Please, is there anybody that can help us in briefly before? You know how much time we have? Any volunteer? Am I being heard?
Good afternoon, Mrs. Lawal.
Yes, you are being heard, ma.
Thank you for the training, for the presentation. This case study actually called for immediate attention. And I think for the first thing the pharmacist has to do is to try to get the case file of that patient so that we can trace the patient, get his details like phone number, address, and things like that. In this case, because we know a number of people now have phone, we might need to just call straight. The patient is either way, since you know it's your error, you can just go and look for the patient in his or her house. But if you can first get a call through to him, stop all the drugs, don't take any. We're on our way to exchange the drug and things like that. Then you might need to confide in your HOD as well as the prescriber that this has happened. and we want to stop it. If it's in a community practice, you just have to find a way of getting the patient. And that will actually also, as community practitioner, for things like this, we might need to be taking notes, taking addresses. Personally, I've had to run after patients when I discover that maybe I made a mistake in maybe dispensing or giving the correct thing. Just quickly, it's like immediately they step out to just realize that there's a mistake, there's an error, and just run after them this way, that way, to make sure that you can correct it. At least that's what I can say on this mix-up or error.
Thank you, ma'am. Thank you. Does
In
anybody
addition, ma,
have? Yeah, okay.
good afternoon, ma. Thank you so much, ma, our dear fellow, ma, for how you've been taking us. In addition to what our dear fellow also said, if it's in a community, there's also what we know as know your customer, or you know your client, I say. Now, you are not just managing the person, you are now becoming more like a personal, carer to the person. You have all the necessary information, the data, the phone number, the address, the email address, any way to communicate, just like she pointed out. Then two, I would like to ask the patient if there are side effects, if there are effects, of the ones she's been taking or he has been taking, so that if there's a way I can now monitor or manage the side effect for before I now say, okay, start the amitriptyline you're supposed to be on, or start the other ones you're supposed to be on. Then I also do more of communication to also know, okay, now that we have mitigated the effects we are getting from the other one, now that you have started this new one that you're supposed to be on, what are you feeling like now? Are you feeling better and stuff like that? Then I record that. That will help me. Thank you so much.
Thank you. So let me tell us what we did. Interestingly, it was I don't even know how to put it. It was a new patient. It wasn't a patient that we had handled before. But the person who came to fill the prescription for him was a medical doctor. And we filled the POM book. So we had his records in there. It was as soon as he left that the pharmacist realized the error. So what we did was to trace him. And luckily, because we had his phone number, we got through to him and halted it. So he had not even reached the patient before we solved it. Now imagine if you don't have any record of the patient. And we don't have access to case notes in community pharmacy. These are food for thought for us as clinicians. How do we solve it? And sometimes patients are not very willing to give the information to you, especially when they're new, they don't know you. So what are things that we can put in place? I think we should just start thinking about them. Electronic health records, connection with other healthcare professionals that are managing the patient, because it would have been really bad if the patient had taken haloperidol instead of amitriptyline. So,
hello, ma'am.
Hello, yeah.
Yeah, I just raised my hand because
sorry
for interrupting.
Oh, sorry.
Yes, sorry for interrupting because this question error gave me a lot of concern, because I work in a mental health institution, and I begin to see amitriptyline and the haloperidol. I'm just trying to see. I wouldn't know why this error came up. Is it virtue of the virtue of the fact that the color of the brands prescribed get to the same color? Because we all know amitriptyline to be very, very yellow in color. Their container even those that have blister packets or those have tablets, there multiple tablets, they are already related to the colors of haloperidol. And I wouldn't know the strength of the haloperidol. This haloperidol, the ampicillin usually comes in 25 milligram. Haloperidol comes 5 milligram, 10 milligram. What would have been the mistake? What comes about? I wouldn't know, because if you give me a concern, how could you're just a mistake by somebody that you are dispensing and made this error, so that I can take note on the brands, because it might be the brand.
Distracted. I think the person was just distracted and picked haloperidol and dispensed. And that was why it was even easy to recognize immediately after the patient left.
Oh, thank you very much.
So, you know, there are some by 500 or by 1,000. I can't remember how they come now, but they are retail drugs. So instead of picking amitriptyline, this person picked haloperidol. It was just a case of distraction. So as soon as the patient left was when it was discovered. They don't look alike. Some cases look alike, and that can be a problem. But that tells us that error can occur because we are all humans. And if they occur, what do we do? So sometimes you may even have a system that you have, as much as possible, try to minimize the occurrence of error, but error still occurs. Thank you for your contribution.
Thank you.
So anyone in the treatment chain should be responsible to reject orders. If you are unsure, let's ask, let's validate, let's detect, let's report, let's analyze and feedback. So when these errors, or if errors occur, we should note them so that we can look at what really went wrong, what could we have done better, and then we keep improving on the system. So let's look at this chain of events. If you are writing the prescription, check and check. The prescriber should check to be sure that he wrote what he wanted to write. Whoever is reading the prescription should check properly to be sure that he has read it well. When picking the drugs, check and check again to be sure that you are picking the right drug. Be sure that you are giving it to the right patient. Very important, because sometimes they just write adults and it might be a child. Apart from that, so it's good to know, is this really the owner of the prescription? And while giving the drug, check again to be sure that you are giving out what you need to give. And that's why the process cannot be rushed. Thank you.
Sunday, 7 p.m. on YouTube. And of course, on DSC, 154 classes rewarding couples intimacy.
So let's discuss now.
Remember how moments to look at before every.
I'm open to questions, discussion, comments.
Okay, thank you, pharmacist Folashade Lawal, for such an awesome presentation. Very detailed, very educative. You know, we really learned a lot. So I'll be handing over now to Dr. Timipre Okero-Rene to continue the moderation. She will handle the question and answer and discussion session. Thank you, Ma, once again.
Hello, thank you so much, Ma, for this wonderful presentation. We really appreciate it. At this point, we want to give the floor. We want to for us to ask questions. Please, those of you who are not talking, you mute yourself, please. So now we have one hand already raised up. Please, can we have you?
Good afternoon, everybody. Can you hear me?
Yes, we can.
Yes, we can hear you. You can.
Okay. Good afternoon, Ma. Thank you for the wonderful presentation. Mine is like a suggestion and a comment, because you made mention about fatigue and pharmacists being fatigued, and that's one of the main reasons for having medication errors. So, and I've noticed, I'm a young pharmacist, but I've noticed in some hospitals, some pharmacies are really, really understaffed. So I don't know if there's anything in place for, like, I know of doctors, for resident doctors, for any doctor that leaves the hospital, they must be replaced. Is I think they have that kind of an agreement with the government. I don't know if it's same for pharmacies, because so many hospital pharmacies are understaffed, and most times they overuse interns and youth serving corps members to do the jobs, and by the time they are exhausted, they can lead to medication errors. So I want to advocate that AHAB, PSN, and other pressure groups like the newly found Consultant Pharmacist Association could push this to the government, that for hospitals that attend to so number of patients, these are the established number of pharmacists that should be on ground, that should be employed. Have you even seen a case where the pharmacy was understaffed, and when the hospital was employing, they didn't employ pharmacists, and gradually they employ more pharmacy technicians? Because imagine a place where you have just 3 pharmacists in a tertiary hospital. I'm just giving that as an instance. Where will the pharmacists be able to carry out all the duties efficiently when they are understaffed? I think it's a very, very big problem in our hospital pharmacies that I would plead that those in authority should actually push forward, so that when there are enough pharmacists to handle the patients, the pharmacists can give their best and really identify errors, because you know that the pharmacy is the last point of call. When patients have already gotten to the pharmacy, they are no longer patients. So when you are trying to to identify medication error and so this, they're already shouting, just give me, let me go. And sometimes when you're under pressure, you can also take the wrong thing, because the patients everywhere is overcrowded. I think is one issue we also have to look at. Thank you very much.
All right, thank you very much for your wonderful comment. I believe we can all agree that this is a subject that is extremely relevant to our daily practice as pharmacists, and most importantly to the safety and outcome of our patients. So you've highlighted some points. I'm an hospital pharmacist and I work in a tertiary hospital. I can tell you for free that there are no tertiary hospital that has less than even 30 pharmacists. We have a lot of pharmacists. At a point, we began to create different units so that it doesn't look like we are just all dispensing. And so under the leadership of our former head HOD, Dr. Dan, because I work with Federal Medical Center here in Agua, we had to create a lot of different units where even the ward, we found ourselves inside the ward. In order to avoid this, we have pharmacists are residents in the ward. All the wards, you see the pharmacists recently, we've even entered into the ICU. And so the outpatients, where we have the general outpatients, the A&E who serves as outpatient and also inpatient. You know, their inpatient is not, they don't stay so long because they have to move them to the ward after a while. Then we have the NHIA. Now, what you are describing is what we see in the insurance, where we have scheme. You know, majority of them feel it has been deducted from their salary and they come to crowd the place. And so many persons are under insurance. So you see crowd there. So with that, think our HOD has also used that as a opportunity to make sure that pharmacists posted to that unit are much. They are much. So I think when you have this kind of fatigue where you just described, could happen more. I just feel so in the community setting, especially when they have crowds, most evenings when only one person has to attend to so many persons. In the community pharmacy setting, I feel so. But let me give opportunity to our lecturer. Ma, please, you have the floor. What he has said so far. You can make your own comment. I know you are a community pharmacist. That's your area, Ma.
Thank you. Well, like you said, some community pharmacies probably might not have enough pharmacists to work. Then they just have to find a way around this, probably roster them in a way that it will not be too stressful for the few that they have. The hospital pharmacists will depend on government or, like you said, your own head of units who made representation to ensure that pharmacists are employed. Pharmacists are going out of the country like other healthcare professionals. In Nigeria, the ratio of pharmacists to patients is rather ridiculously small, and that's why we need to leverage technology as much as possible. With technology, we'll be able to achieve a lot more than what we are doing right now. So it may not be easy for any community pharmacist to have so many pharmacists at a time. But technology can make it better. When you already have your patient data, and to enter patient data, it doesn't have to be a pharmacist. You delegate, you just leave the pharmacist to do the core pharmacy practice. You can engage technicians to help out with the non-core pharmacy practice. So we can still find a way around it, really, if we want to. That's my thoughts.
Thank you so much, Ma. Thank you. And like what he commented, I want to agree with you when it comes to states, maybe hospital management board and the Ministry of Health. I noticed they have that kind of lacuna. In my facility, for instance, we have 70 pharmacists. Then our pharmacy technicians, we have about 35 of them. Then we have our support staffs, the clerical officers, the scientific officers who help us do all this documentation so that pharmacists will face their work purely. But I don't know, maybe those in the state hospital can also make contributions. We have Emmanuel Ede, your hands are up. Please, can we have your contribution or your comments? Thank you. You have the floor.
Thank you very much. I would like to start by apologizing that I joined in quite late because I was away from office. So it's a question, and I wouldn't know if it was addressed in the course of the presentation before I joined in, but however, if it has, then I apologize. I'm taking you back. My question is from our experience in the community setting, where a prescription comes to a community pharmacy, and a pharmacist has been able to identify drug therapeutic problem. And ordinarily, the ideal thing is for the pharmacist to reach out to the prescriber, secretly without having the patient knowing what is happening, and then the correction is made. But in a community setting, where your prescription is coming from and outside the setting, and most of these prescriptions these days, you don't even have the details of the prescribers. You don't see a phone contact that you can call. Sometimes they just see a signature, no name. And so it becomes difficult for the pharmacist to be able to reach out to the physician to get the necessary correction done. And then pharmacy does not have that legal. Hello. Can I go ahead?
Yes.
Please.
I can see the background. I can hear background.
Hello. Please help us. You can go ahead.
Okay, because I hear a lot of.
I'm just going around.
Okay, so the pharmacist does not have that right to change the prescription on his
sure.
own. And so I would like
You
the
just correct
presenter to help guide and advise on what to do in such a situation where you see a problem. You are now faced with a situation where you need to change, if possible, but you cannot reach out to the physician. I don't want to say or do anything that will make the patient eventually look down on the person who has given the prescription. So I would like us to be guided and what to do when we're faced with such a scenario. Thank you.
Okay, thank you very much.
I would like to respond, but there's so much noise at the background.
Dr. Bello, please, can you help us mute yourself? Dr. Bello, the news is coming from your Tipa National, the noise is coming from your side.
Okay, thank you, Pharmacist Dede. That's a very interesting question, and it's something that will come across a lot in practice. So there are different approaches to it. Sometimes you might have to look for the hospital. That we had to go to Google Map to get the address, the phone number of the hospital. We called the hospital, and then we went through the receptionist to get to the doctor to solve whatever it was. There are times that you do everything at your disposal and you cannot reach the prescriber. When it comes to that and you cannot change it, it is to get the patient to either go back to that doctor with a written note or get a second opinion somewhere else. One thing I do not do is tell them that their doctor has made a mistake or is wrong. I might say, I'm not clear on this and I don't want to give you the wrong thing. Or I've not been able to substantiate this, so I cannot go with it. In your own interest now, I'll make it about the patient. I'll let the patient know that, see, we have this drug. We need your money, but we want to be sure that this is what your doctor really means. And the same thing we do with the doctor. Sometimes when we are able to talk with the doctor directly, the first thing, I'll go away from where the patient is, call the doctor and say, Dr. This is, I'd like to address myself as lead clinical pharmacist so that there will be some respect. And then I will say, sorry, where I am, your patient is not there. I've moved away from your patient. I noticed this and that and that. I've not been able to substantiate this from literature. I need your guidance. Then we will talk. I need the prescriber insists on something that I'm sure is wrong, then I will advise the patient to get a secondary opinion. But I will not change that prescription and I will not dispense it if I'm not sure or if I'm sure that it can harm. So it depends on what you have on your hands. There are so many ways. And when you do that consistently, you get respected for it. Over time, the people will, other healthcare professionals will want to work with you, because you make room for that mutual respect. Very important. Just make sure that you don't run down the prescriber. Don't look at it and say, what nonsense is this person writing? What is this person? No. You just say, oh, I'm sorry, I need to clarify something here. And then you go ahead and walk around it. I don't know if that's satisfies you. If not, we can have another day because a whole lot of issues, communication skills, so many skills, soft skills that come to play. We can have another program to address that separately.
That's okay. That's all right. That's fine. I'm clear.
All right, thank you so much. I can just add that if your community pharmacy is close to maybe an hospital, you can go an extra mile to know the pharmacists in that facility, so that if you cannot reach the physician, just like you've mentioned, no contact, no nothing, you can reach the pharmacist in that hospital, and they will help you. They will help you connect to the physician. Most of the time, why patients go outside is either it's out of stock, or they feel it's better because of stress. You tell them go here, pay here, they there, so they rather just buy their drugs outside. But if it's a facility that monitors where the way some are beginning to do now, you don't even get to see your prescription. Everything is just computerized and they give you medications. But because of our gap in government, most governments, facilities, you begin to see patients go with their prescription, even bring it back next time, they have a copy and all that. So it's part of the problems that we have in Nigeria. But as a community pharmacist, I think you should go extra mile, try to know the pharmacists in that facility, so that when you have issues, if you cannot contact the physician directly, then you can contact the pharmacist. They will tell you where the prescription is coming from, and they can even search the folder to find out what the problem could probably be. And there are some questions you can even ask the patient too. You can ask the questions, patients some questions. There could be reason why some drugs are written that maybe it depends. So there are some things you really need, so I think you should go an extra mile. You'll be able to sort that out. Then I have Dr. Olanike Kehinde. Please, Ma, you have the floor.
Thank you very much. Good afternoon, everybody. And I want to thank our lecturer, my friend, Mrs. Lawal, for doing a very good job of this, as expected. Thank you very much. And also for punctuating the presentations with real-life practical examples to bring home the points. Thank you so much. I just want to say to us that as pharmacists, we have to always be on top of our game. Let's show that we know our onions well. And sometimes we may come across certain dosages different from what we are familiar with. Let's not immediately just assume that, oh, this is wrong, because it's not what you are familiar with. We must be conversant with our official books. We need to, check our dosages, the indications from our official books, because sometimes, there are off-label indications. So where, like Mrs. Lawal just said, we must try to get back to the presenter. Don't just let the patient make the patient to think, oh, this doctor does not know what he or she is doing. Whereas we may be the ones that actually do not know what we are talking about. So check the dosages. Many times, dosages are actually by weight now, even for adults. So yeah, there will be the upper limit, but we need to cross-check and be sure. And then where we think there are discrepancies, where possible, let's go back to the prescriber. And she has cited so many instances of her doing that. As in the community, the pharmacists should try to be familiar with the hospitals and clinics around the prescribers and the pharmacists there. And like she said, when we relate with them with respect, and when they get to know that we know what you're talking about, they will definitely respect you and listen to you. So let's not just assume, let's contact them. Collaboration is actually key. When we know that the patient is the focus of our care, we will not think about ourselves. It's not about us, neither is it about the prescriber. It is about the safety of the patient and getting the needed positive health outcome for the patients. So my point is, let's cross-check things from our official books. And thank God everything is online now. We should have Medscape and other reference books on our phones that we can easily cross-check with a click of a few buttons. Also, for children, dosages are by weight many times. For instance, for loratadine, even if you have a child, once they're above 30 kg, it will be 10 milligrams, and so many other things like that. She's talked about dosage adjustments with renal and hepatic impairment is very important. Yeah, this may be a bit difficult in the community setting where one may not have the history of the patient. But when we come across certain unusual dosages or drugs for some indications, let's discuss with the patient. If the patient knows, yeah, then you may now check based on the information you get. Because, for instance, I was quite surprised. One day I came across a prescription for cefuroxime that was 250 milligrams once a day. And for what may come to mind is that, does this person know what they are doing? You may just think it's an error. But on further check, the patient has kidney failure. With that, in that case, cefuroxime is actually supposed to be given once a day. So let's not be quick to think a prescription is wrong. Let's cross-check doubly and severally before taking the necessary steps. But let's, as much as possible, get back to the prescriber to discuss where possible, and where not possible, like she said, you can now refer the patient back. So, and it's important to own up to our mistakes. Don't try to cover up, particularly because well, there may be some disciplinary action. In the interest of the patient, let us own up to our mistakes so that it can be corrected promptly and the patient will not be harmed. There is a patient bill of rights, and I know that also in Nigeria, over time, we will get to it where litigations may become the order of the day. That should help to keep us in check. So as pharmacists, let's continue to put the safety of our patients as our uppermost, give it top priority, and let us continue to update ourselves using various avenues. Once again, I want to just say thank you to Mrs. Lawal and the organizers. Well done.
Thank you, ma'am. In fact, you raised a lot of points here. Like I said, we could spend the whole day. It's an area of passion and common interests. So there's so much and so much to be said. Getting to know I have had to go to Association of General Practice Medicines in my community to do medication errors talk with them. I subscribed to that time. I went there and we had discussions around it. So, and that way they respect you. You must not talk down on anybody or look down or make the patient think that that person is wrong and you are right. No, it's not about that. Sometimes when patients even insinuate it, I tell them, look, doctors' training are different from ours. It's my business to know that there's a wrong medication. The doctor is trained to diagnose and he has done that work properly. This is now where I come in. So we must respect one another. We must give room for errors that can occur because we're all humans. And don't ever outrule what somebody has done without having a conversation with that person. No, that won't be fair. Somebody writes something and then I just say, oh, what rubbish has he written? Then I prescribe and not fair on the patient. So it's important that we get it right and we bring in a law. Like I said, we might need to have another day to look at all of the skills that we need to be able to get it properly, right. But we just have to get it right. Sometimes we go through pharmacists in other establishments. Oh yes, there are pharmacists here that might be here that know that we call them and we will not rest until we have solved that problem. We will go from whoever to whoever and continue until we have solved it. So it's our business to ensure that our patients are safe. It's our business to ensure that we avoid medication errors. That's our calling. And anything that it takes from us to do it, let us give it. Thank you.
Wow, thank you so much, Ma. We really appreciate you. Because of time, we may not be able to take more questions. So I would like to sincerely appreciate our presenter today, Mrs. Folashade Olufunke Lawal, FPSN, FNA Farm, MFarm, DCP, MCPAN. As we know, she's a seasoned community pharmacist with over 3 decades of experience in pharmaceutical practice space and also in public health advocacy. So thank you, Ma. We are so happy that you shared your wealth of knowledge and experience with us today. Like you have mentioned, we would like to have you again. You did mention that anything when it comes to this, there's a lot to talk about. So we are really hoping that under the specialty Drug Information Pharmacies of Nigeria, DIPN, they could have their, and then share it to all platforms. We are just featuring the specialty group in CPAN National. But that does not mean the specialty group cannot go ahead with what they are doing, and they share it, and other people will still join. So I want to use the opportunity to talk to Dr. Bello Kolawole, who is also who is here now as CPAN National, is our ICT guru, and is one of the desk officers in drug information. Please, we want your. I know people have a lot of modules, module 1, module 2, module. This particular topic is one of the modules in your among your presentation. So want to plead with you guys to come up with something maybe next month, and then keep it going the way it used to be. It's been long we actually saw Drug Information Pharmacies of Nigeria come up with something like they used to do. And with that, you see so many persons will join. So at this point, we call on the Education Committee Chairman first to say something briefly before I will now call on our CPAN National Chairman, who is on the call. So our Education Committee Chairman, you are here, Pharmacist Ifeoma Moma. Please, can you just say something briefly, generally about this whole presentation before I call on our National Chairman? Thank you, ma'am.
Thank you very much, Dr. Timi. Dear standing moderator for the day, we appreciate your support in spite of our ill health. Agree. Then I want to, especially thank our lecturer for the day, Famfolashade Lawal. We appreciate you, ma. Met you just barely 2 weeks or so. You were able to come up with this wonderful lecture. We thank you for the sacrifice. We thank you for, having us in mind. And you actually did a very wonderful job. Thank you so much, ma. We appreciate all our participants that are on the call. And we encourage you to keep on joining our CPAN clinical meetings. You always gain a lot. Then I have concern about one of the comments. I think that was a certain Ozia Benjamin. I don't know whether he said he's not a pharmacist or he said he's a young pharmacist. That comment actually struck me because he said something that reflects what we are currently going through in my place. And I believe it happens in some other places. So when I was hearing the response that he was giving, that tertiary institutions, they have like 70 pharmacists and all that, I was like wondering, I was actually odd because it doesn't happen in my place. It's not happening in my place. He said exact reflection of what is currently happening in my place. We are seriously understaffed. And on that note, I still want to lend voice to what he said, pleading with the authorities that could do something about it, the AHAP, PSN, and the current ASCOP, Association of Consultant Pharmacists, and Dr. Timi, you are even one of them, to still help us advocate for more pharmacists to be employed so that this issue of patient safety, medication errors, will be minimized a lot, or rather will be attended to as it should. So thank you very much for, helping us out with the moderation. Thank you, our lecturer. Thank you, participants. Over to you. Thank you.
Oh, thank you. Thank you so much. Our wonderful, hardworking, energetic pharmacist, Ifeoma Moma. That's our Education Committee Chairman. She makes sure that the roster, if the roster says so state or so specialty group or so person is going to present, she makes sure it happens. You recall that this particular presentation was scheduled for last week. We had network issue, and then we now rescheduled it to today. So she has been behind making sure that things work out well. And also our ICT guru, Dr. Ibrahim Kolawole Bello, is always behind the screen. Once you see SIPA National, just know he's the one there. No matter the kind of presentation, whether he has chance or he is always there. So we want to specially thank you and appreciate you for all you do for SIPAN, and pray that God will continue to bless you just as he has been blessing you. Thank you so much, sir. At this point, I call on our SIPA National Chairman, Dr. Maureen Uwafo. Ma, please, you have the floor, and you give us vote of thanks too. Thank you, ma.
It's good afternoon, dear colleagues. I'm glad that today you already listened to this wonderful presentation. I want to start by thanking Drug Information Pharmacists of Nigeria, ably led by our dear Dr. Bello. Thank you so much for organizing this wonderful presentation. And our dear Education Committee Chairman, Famifama Mama, thank you so much for your hard work in making sure that we'll continue to get this important education almost every week. I want to appreciate our dear erudite scholar, Pharmacist Folasade Lawal, Ma. I really know what you can do. I'm not surprised. Thank you so much for making our time to come here again, once again, despite your tight schedule. We are really blessed to have you in our midst. I want to appreciate all the NEC members. So many of us attended this lecture this afternoon. Thank you all. I saw IPC, Dr. Ami Bokinsley. Thank you for joining us, and the other key stakeholders in PSN. I just want to encourage all of us, to be watchful. We are clinical pharmacists. Our duty, the priority that we must have for our patient is to always prevent, identify, and resolve any medication error, however it may come. But you do that by make sure that you have a team that you're working with. We cannot do it alone. It must be a collaborative practice. And bear in mind our pharmaceutical care definition, you must be responsible in providing the pharmaceutical care services. So we should be watchful, have a teamwork, and always try to resolve any issue that may arise once it concerns drug therapy. We should have protocols, SOPs, checklists. All these things will help us to minimize medication errors and thereby improve our patient health outcomes. Thank you once again for joining us. See you once again. Thank you. Have a great evening.
All right, thank you also to everyone who joined and participated actively in this clinical meeting. I believe we are all living with something practical that we can apply to improve medication safety and ultimately improve patient care. Once again, thank you very much, Ma, and thank you everyone for joining us this afternoon. I'll call on Pharmacist Abiola. I can see you on the call. Please help us with the closing prayer. Thank you.
Thank you very much.
Okay, is it my Abiola? Is it my Abiola? Okay,
Yeah,
okay,
bless
okay.
you. Two Abiolas on the call. So the one with only Abiola, please, can you help us with the closing prayer? Thank you.
Father, in the name of Jesus, we thank you for the opportunity this evening. We thank you for the vessel that you have used to bless us this evening. We say thank you. Thank you for all the participants. Thank you for the knowledge we have gained. But thank you because it will be useful for us and humanity in the name of Jesus. Thank you because as we go, we'll go to your name. And next time we gather, we thank you because all glory shall be yours. Thank you, everlasting Father, for in Jesus' precious name we have prayed with thanksgiving. Amen.
Amen.
Amen. Bye.
Amen. Amen.
Amen.